help patients that they come across. So what had happened in the past, or probably continues to happen, is, and you might have seen somebody, friends or family, had this experience. You go to a health provider, like a physician or a nurse or a physician's assistant or whatever, and the symptoms are related to or some use disorder, like alcohol or some recreational drugs and things like that, or it may be related to prescription drugs. And the medical providers, and this is a span of, we're talking lots of different settings. This could be radiology, dentistry, home health care, nursing, and then of course pediatrics and physicians. And those professionals, what they've told us and what the research shows, is they feel uncomfortable approaching these conversations with their patients, even though their patients assume they would let them know if there was an issue or they had concerns. So because so many substance use disorders go untreated, they decided to develop this protocol. And then I was part of a SAMHSA grant, which is Substance Use and Mental Health Administration. It's a federal agency that helps improve mental health accessibility and provide a lot of funding grants, which we were a part of. And we went out into the community, trained a bunch of health providers, had conferences, invited them to come, provided the training. And this is basically very similar to the training they received. So I thought it'd be great to share, because there's a lot of different disciplines in our program, not only human services and addictions students, but there's radiology, nursing, paramedic, and then there's a few other students I know that have different disciplines. But I wanted to kind of broaden the lecture so it's useful and meaningful information for everyone. Even I think most of our lectures are, but they are usually specifically tailored toward mental health counseling and substance abuse counseling. So let's get into it here. So as I mentioned, SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. So the first step in this could be in a medical setting or a school setting is the screening. So you have an individual who comes in for some type of service that could be medical, or in a school setting, they could go see their school counselor, or a teacher could be working with the student. And once they notice, or they make it a standard to ask screening questions related to substance use, especially specifically alcohol and drugs. And once that screening has vetted out whether this individual might require additional services, so either no, there's no issue after the screen, or yes, there is an indication that they might need more care. So then they're referred to a health professional, depending upon its high risk use or a low or severe, excuse me, higher or severe. And that high risk use would be a brief intervention that the healthcare provider or teacher or professional that you're dealing with would have been trained to provide. And these are a series of questions that are meant to not be judgmental, show care and concern for the individual without making them defensive. It's respectful, it's compassionate, and it's what it's shown is that it in of itself, it helps reduce use, which I think a lot of people would find surprising, but there's been replicated studies where they show these types of interventions help reduce use over time. Okay, so the effectiveness of SBIRT, which is a brief motivational interviewing, facilitates abstinence from heroin and cocaine use at a 6-month follow-up interview, even in absence of specialty addiction providers. So reduction in alcohol and drug use 6 months after receiving interventions. 41% of respondents reported absence from drug and alcohol follow-up compared to just 16% at baseline. So those folks that didn't receive this intervention. Improvement in quality of life, including employment, education, housing stability, 30 days past arrest rates. 95% of respondents reporting no arrests in the past 30 days follow-up compared to 88% at baseline. So what's happening here? I think at just kind of a base human level, when you demonstrate that somebody cares for you, you make a change. We're social creatures. We respond to approval or disapproval from our peers or people in our social circles. And professionals have a unique, how can I say it? A unique position, and that gives them a lot of authority, moral or otherwise. It just based upon the way we, our society is made up. It doesn't always indicate that they should, but it does. So their words tend to carry more weight than maybe somebody in your circle, your social circle, friends, family, and whatnot. So we recognize this is an important opportunity to be able to provide an intervention that can improve the quality of this individual's life by just asking some few questions, spending 5 to 10 minutes addressing their substance use, the relationship to drugs and alcohol, things like that. Also, a number of minority groups are overrepresented with health conditions due to lack of access to care, lack of trust in the medical system, or sometimes their providers are government agencies or clinics that they might not feel comfortable accessing. Also, there's higher rates of poverty in these minority groups. So just across the board, they're less likely to get treatment. So they decided, well, let's put this protocol in place as anywhere we can capture, just kind of cast a wide net to be able to provide this intervention to as many people as we can, because in the long run, the federal government has a vested interest in the overall health of its population, because the healthier they are, the less they have to spend in healthcare costs, which are astronomical. Okay, so just to clarify, the primary goal of SBIRT is to identify and intervene for those folks that are at moderate to high risk for substance use related use. And we're going to start the first process, which is identifying if there is a substance use concern based upon a universal screening tool that I'll introduce to you in a second. But first, I'd like to share this brief video that will kind of clarify some of the processes in SBIRT. Hopefully you guys will be able to see it. If you can't, please chime in on the chat so I can make sure I know what's going on. Can you guys see that okay?
Well, would you extend the window so the video is bigger?
Okay, how about there? Oh, there. Does that work?
Yeah, thank you.
We all know alcohol and substance abuse is a problem that affects more than just the users. When you consider the number of people affected, changing those numbers might seem insurmountable, but it's not. As healthcare providers, we are perfectly positioned to do something about it. That's why we all need to be adept at identifying and addressing alcohol and drug problems. Wait, aren't these things somebody else's problems? Furthermore, why should we care? First, we should care because alcohol and drug problems are common. Studies have shown the prevalence of substance misuse is higher than what we're currently addressing. Our primary focus here is the 20% of people who are at-risk users. These users include the 1 out of 6 patients you see that has had at least one episode of binge drinking in the past 30 days. 1 out of 12 patients meets the standard diagnostic criteria for an alcohol use disorder, and 1 out of 50 meets those diagnostic criteria for a current drug use disorder, including illicit and prescription drugs. Oh, but I don't have any of those people in my practice. Think again. We all see patients who have these problems, even though the problems are often hidden. Why should we care? Because alcohol and drug problems are serious. Alcohol and drug problems cause or complicate a lot of chronic diseases and acute problems. Half of all trauma center visits are alcohol-related. And substance misuse increases an individual's risk of several chronic diseases. Chances are you're already treating these people. Furthermore, alcohol consumption results in over 100,000 deaths each year in the U.S. and ranks third in preventable deaths, following tobacco and poor diet and inactivity. Why should we care? Because alcohol and drug problems are also expensive. Substance abuse is a problem that everybody pays for. Federal and state governments spend at least $373 billion a year on substance abuse. That's $1,486 per person in the U.S. Furthermore, of the total substance-related spending, less than 2% is spent on prevention and treatment, while almost 96% is spent on the collateral damage from alcohol and drug abuse. Shoveling up this wreckage puts a huge strain on the budgets of much-needed programs, including government-funded health care, which must cover most of the burden. This cost is funded by your tax dollars. Okay, so these problems are common, serious, and expensive. So what? There's nothing I can do about them anyway, right? Actually wrong. There are things you and I can do that make a difference. With adept training, small conversations result in big impacts. An important part of adept is SBIRT, a proven method for addressing substance misuse in routine medical care. SBIRT stands for Screening, Brief Intervention, Referral, and Treatment. The main focus of adept training is screening and brief intervention. The first and most important step is screening for risky behavior. A person doesn't have to be addicted to be in a risky category, and any use of tobacco, illicit drugs, or prescription drug misuse is considered risky. Solid population-based evidence sets low-risk drinking limits for men at no more than 4 drinks in a day and no more than 14 in a week. For women and for men over 65, low-risk limits are no more than 3 drinks in a day and no more than 7 in a week. A lot of people are surprised at how low these limits are, but the science is solid. Anything more than these limits is a positive screen. And with a positive screen, it's time for a brief intervention using motivational interviewing techniques we'll learn later in the adept training. But that conversation would just be too uncomfortable. My patients would just lie. They'll think I'm accusing them. But the vast majority of patients say,
"My doctor should feel free to ask me how much alcohol I drink."
If my doctor asked, I'd give an honest answer.
If my use affects my health, my doctor should advise me.
Moreover, there's good evidence from many randomized clinical trials that if we just talk with the risky user about cutting down or quitting, 20 to 30% will do it. These conversations also reduce the risk of another ER visit for trauma. As you've seen, most of the time and energy put into substance misuse is responsive, reacting to the physical, social, and economic consequences. Adept is changing all that. Instead of cleaning up the wreckage, we're getting in front of the train and steering it along a safer route. Learning a few simple skills can make these conversations quick and comfortable for you, and more importantly, helpful for the patient.
Okay, thank you for your attention. It's a short video, but I think it covers a lot about what SBIRT is and what it can do and the importance of it. I noticed that the chat was turned off. Hopefully you guys are able to access the chat now. I was surprised I didn't see anybody. Can you guys chat or access? There you go. Okay, very good. Okay, thank you. Thanks. I was like, oh, why isn't nobody saying anything? And then I looked at the settings. Okay, so looking at, well, I guess I'll take a minute to ask any questions, or if anybody has anything that stood out to them in that short video. To me, the trauma, how alcohol is involved with trauma center visits, I thought that was really striking to me the first time I watched this video. I haven't watched it a number of times, but every time I watch, those numbers always astound me. You can kind of chime in through chat. If you want to raise your hand, you can. I can allow you to speak at the the doctor's steering the train. That was kind of a cute little animation, but it paints a clear picture. Raquel is asking how many drinks. If you look here, we're going to get into the audit, which is our screening tool, and I'll be able to answer that question. Yeah, Natalie's talking about, realize how, hey, you might have. I was wondering if it was, Felicia, if that was in 116 or not. Yeah, how little treatment and prevention is provided compared to, how much abuse is out there, Cheryl. I agree. Yeah. Right. So if the more we can, create providers in a pathway for folks that need care, the better everyone's going to be, as the whole, because addiction it's not just the individual harming themselves through their health or their risky behaviors and things like that. It creates, broken families, broken homes, economics, strife, abject poverty, all these other things that happen. Yeah. Taylor's talking about treatment rather than prevention. And yeah, some of these things are preventable, excuse me. Okay, so I want to show you guys the audit because I think you'll find it interesting. We can kind of take it together. And so the first step in SBIRT is determining the severity and risk level of the patient's use. The results of a screen allows you to determine if a brief intervention or referral to a treatment is necessary. And we'll watch a short 16-minute video on what that looks like. Okay, so the audit, the alcohol use disorder identification test. This is a screening tool that can be self-administered. That means you can just give it to a patient in a waiting room, or you can ask them the question themselves and then go over the results with them. And then determine, when you look at the results, you'll be able to quickly determine what you need to do next. So it's 10 questions, self-administered. Interview addresses recent alcohol use, dependent symptoms, and alcohol-related problems. It was developed by the WHO, and so it's free. That's another great thing. It's accessible. You can go to the WHO website and download it. And so any agencies, and I know a lot of you folks are in internship or, practicum, or are going to be going into it. And you might notice that these agencies use these kinds of tools, or they don't use them, and you could recommend them to them so they can kind of see how great our education and training programs are. So some of the strengths, as I mentioned, it's free in the public domain. It's been validated in multiple settings, including primary care. So the research shows that it's accurate and it's valid, and it's brief. So that makes it more flexible, focus on recent use. And it's consistent with ICD-10 and the DSM substance use. I don't know. I'm having trouble getting words today. Diagnosis, excuse me. Some of the limitations: it does not screen for drug abuse, only alcohol. I would say that you can substitute versus alcohol and drugs, and you would and just put drugs in its place, and you would get a good enough screening tool. But it was specifically designed for alcohol because alcohol has a specific effect on folks, where drugs may have more. So even if you're only using cocaine once a week, it could still present a significant problem in your life. The way you score the audit is 0 to 7, 8 to 15, 16 to 19, and 20 over shows dependent use. So these kind of markers based on your score will determine where you're at: low risk, at risk, harmful use, and dependent use. And then where is it? There it is. Okay, I was like, I need to pull it up for you guys. Can you guys see that?
Yes.
Okay, great. Okay, so here it is. And what I'd like you to do, if you wouldn't mind, we'll take it together and I'll show you how to score it right now. So for every response that you have for each question, if it's never, your score for that question is 0.
Would you zoom it out so we can read?
Sure.
Thank you.
I'm going to read them out loud. So, and then you can go ahead and score yourself. So if it's, are you able to see it, Gerardo? Do you need me to increase?
Can you zoom it out so it expands?
Ugh.
There you go.
Let me open this up in. Is that better?
Mhm. Yep.
Okay. Okay, sorry about that. I have this giant screen at my house, so when I share my screen, it gets all funky because a normal size screen is, you know. So taking it just to go over the scoring process or how you're going to score yourself is once you read the question, your answer is 0 through 4. So never is 0, monthly is 1. 2 or 4 more times a month, that's 2, 3, and 4. So for every question, you should have a score over here, like you could write a 0 or a 1. And then when you get down to the bottom, we'll add them up, and these will indicate, your totals will indicate where you fall on that screen. So let's go ahead and get into the questions here. How often do you have a drink containing alcohol? Never, monthly or less, 2 or 4 times a month, 2 to 3 times a week, 4 or more times a week. The second question is, how many drinks containing alcohol do you have on a typical day when you are drinking? Next question, how often do you have 6 or more drinks on one occasion? And then next question, how often during the last year have you found that you were not able to stop drinking once you had started? And question 5, how often during the last year have you ever failed to do what was normally expected of you because of drinking? So you can imagine, like, you know, you don't have to answer the question. Sorry. As I know somebody put a number in there. I want you to keep these to yourself. If you want to share it with your friends, that's fine, your family. And number 6, how often during the last year have you needed a drink first thing in the morning to get yourself going after a heavy drinking session? And question number 7, how often during the last year have you had a feeling of guilt or remorse after drinking? And question number 8, how often during the last year have you been unable to remember what happened the night before because of your drinking? Question 9, have you or someone else been injured because of your drinking? And question 10, has a relative, friend, doctor, or other healthcare worker been concerned about your drinking or suggested you cut down? And that could be a no, but if you're taking the screening and then the doctor says yes, then that might have to change that answer. Okay, so everybody have your numbers and your totals. Hopefully, if you played along, you don't have to, but I think it'd be kind of interesting. So from here, let's go back to the presentation, and we'll take a look at where those numbers were at. And I think I'm going to try to pull up this one at the same time so we kind of see what's going on. So the scoring is actually on the sheet here. 0 is obviously no risk, or 8 or above to 15 is at risk. Let's see. Yeah, at risk. 16 to 19 is harmful use, and then 20 and over is dependent use. And what is really interesting about this, the audit, or I think it's really clever, is that it goes right along with the SUD diagnostic criteria from the DSM. And those of you folks that are taking either the mental health and addictions course or our CPD-1 class for on substance use, you'll notice that. Okay, any questions about that?
Oscar, I guess as a way of sharing with everyone, This tool is super accessible, and it will give you a quick screen of the individuals that you are working with.
Yeah.
So it's easy, it's quick, and due to the shortness of it, individuals are more more open to complete that for you. So keep that in mind as a useful tool.
Yeah. And it's designed to be used by anyone, not just specific healthcare providers or folks that are trained in mental health or substance abuse.
Correct.
That's the portability of it. And Madison had a question. Is this questionnaire is what is used to help assess someone, or is this just an example? This actual audit assessment screening tool is what is used. You don't deviate from these questions because that's what makes the screening tool valid and reliable from a research perspective. Not to say you couldn't ask somebody in your own assessment, like in my private practice, I have an assessment that I use that I develop, but I'm also trained in making specific diagnosis for mental health disorders and substance use related disorders. That was a good question. Anybody else?
Just to supplement that, Madison, your question is great. This is a screening tool. So
Right.
when we talk about assessing an individual, we actually utilize multiple screening tools, and your clinical interview and all that. It's a little more in depth, but this is a beautiful way to start a screening. So kind of a first step thing that you can do as a way to focus your attention more in a client. So just to notice, just to pay attention to the use of word of assessment and versus a screening tool. Two different things, one complements the other. So
yeah, that's it. Yeah, I agree. So I'm looking at a question here. I love all the questions here. These are really thoughtful. Of course, I just lost it. Go back here. Okay, so Corinne is asking, are there any cases where it would be culturally not applicable? I can't think of any instances. Of course, you ask for permission to discuss these things, so you're mindful of individuals, comfort level or autonomy with regarding to this. Do you have any other thoughts about that, Dr. Wentz?
As a clinicians, and those are actually in the medical field, we always want to be sensitive to the individual's cultural background. So when we begin actually assessing and getting data from the individual, whether you are in the medical field or the mental health field, or a combination of both, you really want to be sensitive to those individuals. In terms of the tool being culturally reliable, it has been proven to be reliable. So it has been used in multiple cultures, and they have actually come up with a result that is applicable to multiple cultures. It has been actually translated into other languages. So right there, it's an indication that it's useful for many cultures. That is not to say, though, that you are free from paying attention to your client or to your patient. You always want to be attentive to that individual. It's him or herself or themselves.
Yeah, and I don't, the question about religion, I don't see how religion plays into a factor. It might in treatment, but in screening an individual to make a recommendation for either a higher level of care or a brief intervention, I don't see any issues or boundary violations in that respect. But every situation is different. You want to be sensitive to that. And there's a question about comorbidities. This is a screening tool for alcohol use only. So it is not, but what it's going to tell you is if somebody needs help and to steer them towards getting that help. This is not a full battery of a psychological assessments where you're going to kind of glean different diagnosis and co-occurring disorders and things like that. This is a simple questionnaire that is used to screen for alcohol use disorder and to identify risks. Either it's moderate, there's no risk, there's moderate, there's high risk.
And I think it's also important, Oscar, to mention that through these screening tools, what you get is valuable information that you can send back to the individual so that they develop awareness. Meaning what, if you are concerned as a care provider of risky behaviors, which includes drinking more than average of an individual, communicating that to the client will give them the opportunity to decide whether they want to move forward and get treatment or not. So the idea of assessing, it's a more profound idea, but the screening, it's the beginning stages so that individual begins or starts getting awareness of what is happening to them. This is not to say that you label them as someone that is an addict or someone that is an alcohol user or abuser. Right. This is just a screener, which is absolutely fantastic to use as in the beginning stages of developing awareness, which connects beautifully to the labor and to the work of MI, or motivational interview, that you will see. There you go.
Yeah, thank you for that introduction. So one of the ways that we approach these questions, which maybe can help clarify some of the questions we're getting, is that we do it in a way, MI is motivational interviewing. This comes out of the body of work called Rogers and adapted specifically for addictions. And what it helps is to make clients aware of whether they're interested in change, if they're even aware that there's a problem, and then and to kind of help work through their ambivalence towards change. Like they're not sure if they're ready. And in addiction, especially, this is a lot of the case. Folks know they have a problem. They've thought about quitting. Sometimes they're actively doing something about it. Sometimes they're trying, but they're not successful because maybe they don't have the tools or support. And then through this whole process of understanding what motivates them towards change, they increase their own desire towards change. It motivates them based on their emotional experience. So the first thing is we express empathy, and empathy is the experience of the other. So not looking for my point of view, but trying to see it through the eyes of that individual and their own lived experience. Developing some discrepancies. So I hear you telling me you want to quit, but what you've also said is your continued use. Help me understand what's keeping that kind of dynamic going, because it seems kind of opposing to your interest in changing. And then rolling with resistance if they say, well, I could, but this, but that. Okay, no problem. We're not trying to convince them of anything. I think a lot of times people will just say, well, people just need to hear this. They need to be told this, and then they'll stop. That doesn't work at all. If it did, we would just put banners around the city saying, don't do drugs, and people would stop. But what it does in reality is that entrenches them in their belief system, which keeps them using at those rates or can even make them worse. So we just roll with that. We're not there to help make them change. We're there to provide an environment where they can change. And MI provides those kinds of tools and a supportive environment where that can be done. Okay, there's a lot of questions that are way off our topic, and I appreciate you guys sharing, but I can't get to those questions because they're just too far away from where we're going. So I hope you guys.
Nonetheless, the questions are beautiful. That means
they're interesting, but I'm like, well, we only got an hour here. I mean, and I appreciate everyone's enthusiasm, and I encourage you to share. I'm not saying don't share, but I might not get to some of those other questions if they're just a little bit off base. I'm trying to bring them back to make them relevant, but at the same time, there's a wide variety of interests here, and I appreciate that. So to kind of reiterate what I was saying about motivational interviewing, and for those folks that have, people in your life that have either substance use disorder or behaviors that are really problematic for them and your family and your relationships, pay attention to what I'm going to tell you here, because it's useful when you're talking to those folks, because you probably have talked to them ad nauseum, had conversations and arguments, but nothing has changed. But this is the kind of stuff that clinicians use to elicit change, and it works. And it's been replicated in multiple research studies. And it's a tried and true method for especially substance abuse counselors. So I think it's worth your attention, especially, I mean, all of us have somebody in our life that we wish we could help. And this is the way to do it. It's maybe not in the way you think by telling them to change, but allowing them to express their own motivation towards change and allowing them to reflect on why they might want to change. So it is designed to elicit change from the client. It's not imposed from outside. It's like, you better change, you're going to die. We've seen all those kinds of advertisement, this is your brain on drugs, or this is what drugs do to you. Does that stop anybody from using drugs or alcohol? No. I mean, some people, I think if you get them young enough, it scares the hell out of them. So they might not. But people who are using, it doesn't do anything to them. And also, it just kind of makes them feel more isolated and alone, and also kind of judging you in a way, we don't use direct persuasion. It's not effective for resolving ambivalence. You probably noticed this when you talk to somebody that they're going to go have dinner and they're not sure if they want, chicken or Italian or Chinese food or Thai food. And then you're trying to, persuade them one or the other. Just it creates more ambivalence. Oh, I had Chinese last week, and this is kind of mind numbing. So the counseling style is generally quiet, elicits information from the client. So the client should be talking more than you in this. You should be providing, and I'll give you some examples of how, what kind of questions to ask. The counselor is directive in that they help the client to examine and resolve their ambivalence. So tell me what's keeping you from making this change. Well, I guess all my friends and families use, so it's kind of hard to stop using when I'm in an environment that doesn't really support a sober life. Oh, so does it sound like if you had a place that you could go where you could be supported, it would be easier for you to stop? Yeah. Okay, there you go. So you're just clarifying their own statements and probably providing some direction to that. And then kind of helping the client find out what their readiness is to change. And this can fluctuate from day to day. Today they might be really motivated, tomorrow not so much. And then the therapeutic relationship is a partnership or a companion. You are not the authority. You are not the professional in charge. You are just there to accompany them through this process and experience. Okay. So when you ask people, or when you tell people why they should change, I'm sure all of us have had that experience where they say, you tell people you need to change because of this, and telling them about the importance of change. So, and then how they might go about achieving that change. So is there anybody that would volunteer to run through this exercise with me? And I promise it'll have a happy ending. The first set of questions looks kind of daunting. Okay, Taylor, let's see if I can pull you up in the participant list. And I'm going to allow you to talk. Can you hear? Just unmute your mic. There you go. Can you hear me? Hello, Taylor.
Hello.
Okay, so I'm going to ask you these series of questions, and then there's going to be some follow-up series, so you can kind of see the difference between what most people do and then what motivational interviewing can do. And what I'd like for you to do is give me an example of something you'd like to change about yourself that you're willing and open and you feel safe enough to share within this, this symposium.
Sure. I have a terrible habit of staying up far too late as kind of a...
Oh, great. Okay.
I work a lot of hours and then I have 5 classes. And so it's a lot of my day is work. And I think, well, I'll get back my time by staying up until 2 in the morning. And then the next day I'm really tired and everything takes much longer. Okay.
Now bear with me here and keep in mind it's an exercise, but you will have an emotional response just because we're human. So the first thing I'm going to tell you, Taylor, is that you need to start going to bed early because you're trying to kind of get back time, but that can't happen. So maybe you're trying to kind of cheat the day and make yourself feel like you got a little bit in extra by watching a movie or doing something you enjoy, but that is actually making things worse. Your performance at school, work, and your personal relationships is just worse. So that's some of the reasons you need to change. And if you aren't getting enough sleep, you're going to have health problems. You might develop a substance problem because you might take stimulants or coffee or something else to try to keep yourself up. And then one of the things you need to do is just listen to my advice, make a schedule for yourself to get good sleep hygiene, at least 8 hours a night, and enact it. Okay, I'm done with that script. How does that feel? Me telling you what to do.
I'll say that I've heard it a lot of times from many people, and it's been very, like you've said, very ineffectual.
Right.
It has not worked for me.
Right. And it feels really icky, right? Like having,
it's very critical.
Yeah, and it doesn't have its desired effect. If anything, you're thinking, oh, I'm going to stay up until 2 a.m. tonight. You know,
it definitely encourages defensive-ness, I'd say, rather than the openness and honesty needed.
Right. Okay. Now we're going to ask you the 3 more questions, but we're going to change the format, and I'm going to ask you them, and then we can all kind of share in how this is different. Okay. I'm going to ask you the same question in a different way. Why do you want to make this change, Taylor?
I get home and I cannot focus, and I have to kind of slog through things. I think like, oh, this will give me enough time to do what I want, play some guitar, hang out with my girlfriend, but then I'm too tired to enjoy those things when I get home anyway. Right. So it's just kind of a behavior that is not even giving me the things I want it to.
So it's almost like more work, but less enjoyment or something like that. Okay.
Yes.
Okay. So I'm just reflecting what I'm hearing here. So what are some of the 3 best reasons for you to make this change that are important to you?
I would say I would like to be able to focus and get things done in a quicker, more productive way so that I do actually have that time. I would say I know a lot of information about how lack of sleep negatively affects your health, kind of in a permanent and long-lasting way. And also it makes me irritable, and I'm less able to be present in my interpersonal relationships. And I don't prefer that.
So you'd like to be more present so you have better interpersonal relationships. Is that right?
Yeah.
Okay. So getting more sleep would it make that give you that opportunity?
I would say so, yeah.
Okay. On a scale of 1 to 10, how important is it for you to change? 1, not wanting to change at all. 10, absolutely want to make this change.
Probably like an 8, around an 8.
Okay. It's pretty high. That's pretty
good.
What would get you to a 9? What could motivate you to get to a 9? What would have to happen?
I think if it got to a point where I was actually struggling to complete things by due dates, or my grades started slipping.
Okay, like if just you started becoming unraveled.
Yeah.
Okay. And then how might you go about enacting this change? What's something small that you could do this week that might move that needle a little bit?
I think just set an actual alarm on my phone, maybe talk to my girlfriend, say, hey, keep me accountable. If I try to convince you to let me stay up, just leave and say, no, I'm going to go back to my room now. I'm not going to enable this.
Okay. And let's just do like a thought experiment here. Like, just imagine that tomorrow morning you wake up rested and vibrant and energetic, and every night after that you got a great amount of sleep. How do you think that would change your life? In what ways?
I think just based on what I know intellectually about productivity and sleep and emotional regulation, I probably would get things done more fast and actually have that time and energy for the things I enjoy. And that would be huge for me, because I've been slipping kind of close to burnout because my plate's so full and I don't have a lot of time to invest in myself. So I think it would make a really big impact on how much I'm able to really enjoy what I'm doing.
Okay. In your life. Yeah, it sounds like.
Yeah.
Okay. Thank you for participating. I hope it didn't scar you too much, but I hope everyone can see how all I did was make a couple changes in my approach and how the effect it had on the conversation and the interaction. And of course, this is very simple. Anybody can do this. And I wanted to show you guys the power of a good counseling skills are, because I think sometimes they're overshadowed by our own desire for people to change, kind of making the world the way we think it should be. And that doesn't work, and if you want to enact change in the world, the research and the clinical skills that we are teaching you in our coursework in the human services programs is the way to get there. All these other methods fall flat, and they have for years, and they continue to. So I'm gonna take away your ability to talk, Taylor, but thank you. I really do appreciate you having a little discussion with me.
I want to share with everyone too, Oscar, just as a supplement and complement of this beautiful exercise. Mr. Sida is totally on point when he says those are mastering your skills. You can see that he's a clinician. And the beauty of it is that you can actually see that you allow the client, in this case Taylor, to just manifest why is it important to change. And we went from the why, the reasons, and then Mr. Sida actually calibrated by asking from 1 to 10, where are you? And then he just went to say, what can we do today or this week to move it to a 9? And then he threw a beautiful skill that I love seeing in sessions, this miracle statement, which is actually in solution-focused approaches, the miracle question. How would your life be if you wake up one day? That allows the client, which I keep saying I absolutely love seeing this in action, that allows the client the possibility of imagining the change. It doesn't even need to take place physically. It's already been, I want to say implanted, but it's not implanted. It's already been given to you in your ability and your cognitive possibilities to imagine the change. That in and of itself mobilize the individual to change. So thank you, Oscar, for showing us that. I really appreciate it.
Thank you. I appreciate the compliments, and also just expanding what is happening, because these are mastery level clinical skills, but I know you guys can do them with a little bit of training. And that's why I present them to you in our program, because I want you guys to be in the field ready to go. And when I learned them, I was thinking, why did it take them so long to tell me about these things? So in my own endeavor when I developed this program, I was like, this is going to be early on. It's going to be the base skills for our program. So, okay. So going back to the MI principles of empathy, discrepancy, rolling with resistance, I really didn't get any resistance from Taylor. That might just be an artifact of the setting. And then supporting her own self-efficacy. What could you do? What are some things that you could, not me telling her what she should do? Anybody have any thoughts or questions about that intervention? And when I'm working with a client, I believe everything is an intervention, from the tone of my voice to the presentation of my person, to the office being clean and organized and well kept. My apologies, Taylor. I just, and I think I knew that from talking to you over. It doesn't work to our advantage too with just audio. But yeah, I'll be mindful to remember that. Thank you. Thank you for letting me know.
And Oscar, I just want to mention too that I profoundly believe that a foundational, not to say that the other ones are not important, but a foundational element of MI is the empathy. Mm-hmm. You are not in the session to change no one. You are in the session to facilitate a process with kindness and empathy, without pushing your agenda, without pushing your knowledge, your ability to think, but just to allow it to flow. So at least for me as a clinician, that empathy it's everything. It sustains the entire process. Mm-hmm. In the moment that your mind skips and start thinking about you should be doing that or should be changing that, is in the moment when your empathy is actually distancing from you. So this total regard and care for the individual while you facilitate embraces the change in and of itself.
So Morgan had a question. Thank you, Dr. Wentz. Morgan had a question. What are the ways you would roll with resistance? So like, say, for example, Taylor said, well, I actually don't want to change. I like staying up late. I think it's awesome. I like to play video games and drink Dr. Pepper all night and pass out at 3 a.m. and wake up and run around. I would just, okay, because it's not, if the client is telling me they don't, this is where they're at, then I honor that. Okay, that's what you want. Even if they tell me, and it sounds like a terrible idea to me, that's not my place to make that judgment, because we have to respect the individual's autonomy, their right to choose their own life and the way they want to live it. And so rolling with resistance would be if I said, well, you said you were going to change and now you're not. Well, I guess I thought about it and I don't really want, I mean, I want, let's say I want cannabis to be part of my life. I have this all the time in my practice. They'll tell me I'm willing to work on things, but I don't want to remove that drug from my life. And I'm like, okay, I hear where you're at and I accept that, and let's work around it the best we can. But I have to also warn you that abusing substances that are altering your minds are probably going to interfere with the change process and your ability to learn and adapt. But I'm okay, you know, I don't think that it's going to actually yield the kind of results that you want coming to therapy while you're using to the degree that you are. And I'll have to point that out at some point, but it's not personal for me. So.
And I think just to add on to your response, resistant, it's at least the way I see it as a clinician, a term that can be the perception that you have of a resistant, or the desire of not changing, or just a process that is taking place in that moment. Because Taylor saying, I don't want to change in this session doesn't mean that he doesn't want to change. It means that in that moment, I don't want to go. I don't want to do anything. I don't want to mobilize from number 1 to number 2. Actually, as a matter of fact, I don't even know why I'm here telling you that I want to go to bed early. And that is totally fine. But there is a key element that Mr. Sita mentioned at the beginning. Everything is an intervention. So if someone picks up the phone and say, can I set up a meeting with you or a session? It's already something there that needs to be taken in consideration. So if the individual is coming to you and saying, I don't want to change, even the question of, thank you for coming, help me to understand you because you scheduled this session with me. What do you think is happening in this moment? So this idea of rolling with the resistance, departing from the idea of how you are looking at it. Maybe the client just needs more time. So it is your job to remain there despite the fact that your mind is like, stop smoking, stop drinking, stop using the cocaine, you're killing yourself. The idea of, can I be present regardless of how my client or the individual in front of me is actually manifesting in that very moment. So to remain open, in other words.
Fawn has a really interesting question. Why is it easier? I mean, this is a big question. I don't even know if I could answer, but I think it's important to hear. Why is it easier for people to listen and do what is negative than positive? When we try to change people for the better, it doesn't work. But when you say something harmful, they tend to listen to that. So when I say, when I insult or criticize, well, I think it has a lot to do with how we already feel about ourselves. So when people, and remember, we're not trying to change people that are high flyers, people who are well adapted to life and to society, into their harmonized, their individual lives with the lives in those social circles. We're not talking about those folks, okay? Because if you did criticize them, they might tell you, well, I'm just happy in the way I am. So they might not have that same reaction. But I think when there's folks that are struggling and things like that, we have our own negative self-talk that we tell ourselves, and it touches on that, and it resonates with them probably stronger than some of these. It also it feels like it hurts more too, I think, and that elicits a response of feeling rejected by those that are close to us, or whoever's giving you that advice, which a lot of times can be somebody that is in your social circle. Yeah.
I will agree with you. And the question is very heavy, super deep, and the individual that it's not that everyone does that, right? Some may prefer a kinder and more empathic way of addressing them, and others may prefer the negative. But even then, the question of why is that preference? It's
and another kind of way to reflect that your question, Fawn, is why would you want to ask questions in that way that don't produce any kind of results, when now that you've seen an example of how you can use a series of questions that allows the individual to make the determining factor, whichever way they decide. So I think that's what we need to do. And this is not saying having people have a pass or let people do whatever they want. No, this is asking these questions that they brought up that are important to them. Okay, let's kind of move on a little bit here. So the steps in the brief intervention, the first will be building rapport, raising the subject, asking if it's okay to explore it, exploring the pros and cons of use, and then providing some feedback. Building a readiness to change within the individual. I did that. I did all these things pretty quickly, and they hopefully they're invisible, because otherwise you might notice it, and that could be me delivering it kind of in a clumsy way. And then negotiating a plan for change. And we're going to watch a short video. It's 16 minutes long. I hope it doesn't bore anybody, but I think it's important to see the skills. I tried to demonstrate them briefly with Taylor, and I appreciate him, being a little guinea pig for us in front of everyone. We didn't plan this or anything. I just glad he was courageous enough to give me the opportunity. But I want to show kind of a different approach, a similar, but somebody else doing it. So let's look first at the brief negotiated interview and active referral to treatment provider training algorithm, which basically means some good questions to ask somebody if they're having this issue or concern. Okay, hopefully you guys can read that. Where's the chat? Oh, the chat's right there.
Yeah, would you do the Adobe like before? So
okay.
It zooms out.
Okay, so let me move the chat off here. Hopefully you can see that. It's too big for me. So here's the skill base here, building rapport. And over here on this side are some examples of how you might do that. So building rapport, raising the subject. Hello, I'm Professor Cito. Would you mind taking a few minutes to talk to me about your alcohol use? Before we start, can you tell me a little about a day in your life? Where does alcohol fit in? And then some pros and cons would be, give me an understanding through your eyes, the good things about using alcohol. Well, it's fun. I like to get drunk and relax with my friends. What are some of the not so good things? Oh, I spent a lot of money. I got a DUI last year. My health is suffering. Okay. And so on the pros, you like to have fun, relax. And on the cons, you had some legal issues, health issues, and economic issues. Is that right? Yeah. Okay. Then providing some feedback here. I have some information about the guidelines of low risk drinking. Would you like if I shared it with you? Sure. Okay. Well, we know that 4 or more drinks for females and 5 or more drinks for males. And if females and males, the reason they make that distinction is because it's usually size. So that matters more than gender in this case. But I think that because males tend to be larger, way more, things like that. Drinking in one sitting or having more than 7 for females, 14 in a week, or the use of illicit drugs can put you at risk for illness or injury. You can also health problems like diabetes, mental health issues like depression. What do you think about that? So, okay, well, that's, I kind of knew that already, and I'm probably starting to feel it already. But that makes sense. And I'm kind of surprised that the number of drinks is so low, because I'm probably, throwing back 20 to 30 a week. Okay. And readiness to change. Okay. Taking a look at this ruler, on a scale of 1 to 10, where do you feel you're ready to change? 1, not at all, 10 being completely ready. Well, I guess maybe like a 7. That's great. That means you're about 70% ready to make a change. So just kind of reflecting that in a different number is kind of motivating him. Why did you choose that number and not a lower, like a 1 or 2? It sounds like you have some important reasons to change. Well, yeah, my health is going to get worse. I'm tired of being broke all the time because I throw all my money away at the bar. And so what are some steps that would work for you? Well, just limit the number of drinks. Instead of, doing 20 or 30 a week, I can keep it under 10 and see how that goes. And what do you think you can do to stay safe and healthy? Well, drink at home, or make sure that if I am drinking when I'm out, not driving. And like I said, drinking less. Tell me about a time when you overcame challenges in the past. What kinds of resources do you call upon? Which of those are available to you at the time? Well, when I was in high school, I was in track, and I used to run long distance running, and I really just kind of buckled down and stopped drinking, went to bed early, ate healthy, and I felt really good about myself. And I was able to, we won state that year, and I attribute it to those changes that I made. Okay, and then prescription for change. Will you summarize the steps you'll take to make this change? I've written down a plan, and this prescription to keep you as a reminder. And then, if appropriate, outpatient counseling. Suboxone, this is if there's opiates at play here. Needle exchange, primary care, mental health, shelter if there's no housing, handouts and information. Okay, so that's kind of an example. So now you'll have this to look at to give you kind of a guideline. And this is, Boston University School of Public Health. So great resource. Huh? They got a lot more faculty than we do. So I'm glad they developed it. I just grabbed it off their website. So then going back to the presentation here, let's watch this in action. You've seen me do it. I've walked you through some of the questions, showed you kind of some of the attitudes and ways of approaching the individual with empathy and not a kind of a non-judgmental tone. And we'll watch that here. Okay. But before I go in there, is any questions here? I'm sure some got by me, but ask the pros and cons. Yeah, that's a great one. Shauna, I agree. It helps them think about what's good and bad for them, not me telling them, right? Okay, so here we go. Hopefully you guys can read it. If you can't or see this, please let me know. Oh, it's 13 minutes. So everybody can see that okay? And hear it?
Could you sort of summarize what you see as the essential elements and the essential sort of skills and strategies that you've used in these interviews?
I think the first is really building a collaboration from the get-go, showing you're interested and really listening attentively to the patient, giving 100% of your focus, and then using some well-known motivational interviewing strategies. The basic ones are the open-ended questions, reflecting, affirming them, summarizing. I try to do that quite frequently. And then maybe bringing in one of the techniques like a readiness ruler, the pros and cons, some of these techniques that are so helpful to get people to take a look at their behaviors and where they are right now.
Hi, I'm Marsha Cox.
Hi,
My GP sent me in.
Nice to meet you.
Nice to meet you.
I'm Dr. Turner. I'm the health psychologist here at the practice. I'd like to get to know you before we get started, but I know you're probably wondering why your GP did send you in.
Yeah.
Okay, your GP sent you in because when she had you take that secondary screening tool, I don't know if you remember the one specifically for your drinking,
Oh, yep.
the scores on that tool and some of the ways you were drinking concerned her. And so she thought it would be good for you to come in and talk to me for a bit. Hope that's okay.
Okay, sure.
And that's not unusual. In this practice, a lot of patients will come in and see me after taking those screening tools.
Okay.
Is that okay?
Yeah, no, sounds good.
All right. So before we get started with that, it's always good for me to just spend a minute or two and just get to know you.
Sure. I just finished my second year of grad school. I'm getting a degree in environmental policy.
Wow. That
Yeah.
sounds interesting.
It is. I really enjoy it.
Where can you see yourself ending up with a degree like that?
Well, my fiance, Ben, is interested in international politics, so we're thinking about going abroad after we get married. Yeah.
In grad school, it's going well.
Yeah.
Thinking about maybe traveling abroad. Thinking about marriage.
For sure.
Sometime soon and having a family. What do you do in your free time?
When we have it, which right now is pretty often, we get outside as much as possible. I have a big group of friends. We just went whitewater rafting last week.
Wow.
Some rock climbing, nothing crazy. I like to host parties at my house. I like to cook, so sometimes we have people over.
So you're social.
Yeah.
You get outdoors.
Yeah, we have a good group.
All right, so let's get back to why your GP sent you in to see me. Right? You showed by answering the scores as honestly as you did that your drinking level is putting you at risk. And now that you're also thinking about having a family, that also might be even more, add to the concern more. And I'm going to sort of look at this around the alcohol. Where does the alcohol fit in there?
I guess my worry as to why this is a concern is because I feel like so many of my friends drink as much more than me.
Yeah.
Almost everyone my age that I know.
Yeah.
And they're all very busy, active people. It's just something that we definitely do on the weekends, definitely. My fiance probably has a drink every day. Yeah.
So it sounds like, and almost like a surprise. Wow, I can't believe that I'm even being asked to come see me. Right?
Yeah.
When my friends drink, my fiance drinks. And
Right.
if anything, they drink sometimes more than I do.
It's something I'm aware of, and I haven't always said this, but I definitely feel like, I don't want to be drinking this much when I'm 30. I've definitely had that thought. And especially if I'm starting a family, I don't see that as part of, my future.
Okay. So you even have noticed that maybe as you get older, it might be good to sort of bring it down a little bit?
Yeah. I mean, I'm aware of it
Yeah.
for the most part.
Yeah. All right. And so let's talk about it a bit. So what I read in your answers was that you're drinking about 3 or 4 the nights that you drink. Does that seem accurate? And
Yeah.
that maybe once a week you might go out and really have a good time and let loose and have more than 5?
That sounds
More than
right.
6?
Yeah.
Yes. And the one thing I want to say is it also said that you're not doing any drugs. And you're shaking your head like, of course not, right? Is that right? Yeah. But that's really nice. We deal with a lot of patients here and some have both. But in this case, that's really to your benefit, that it's really strictly, we're talking about alcohol. Okay. Is that right? And so it's really seven drinks a week is really the safe limit for women. And that what happens is doctors get concerned, and the research shows that when you drink more than that, you could be at risk for medical complications with your drinking, right? And also psychological ones, relationship ones. And how's that sound? And you know that your drinking is putting you at risk.
Yeah. I mean, I'd prefer to be healthier, I guess.
Yeah.
It's definitely it's not something I've never thought of, as I said. My parents and my brother have had some issues with it, so.
Yeah. So if we were to write down some of the pros and cons of your drinking, just to understand them, it's always good for me to know why people, when they drink, like to drink, and even maybe for you to figure out, and then figure out what might not be so good about it.
Okay.
We can get into that. So what are some of the pros?
Well, definitely the social aspect.
Okay.
It's fun,
It's fun.
you know?
What is it about it that makes it fun for you?
I think when we're all together and we can all feel a little less inhibited, my group of friends, that's definitely the primary place where I'm drinking the most with my groups of friends, for sure.
All right. So it sort of loosens you up, it gets you less inhibited, and
Yeah, definitely. It's a way to let go on the weekends.
way
And
to
I'm
let
not thinking about
go,
those papers.
way to have fun, loosens you up.
Yeah,
So it's definitely a social
yeah, yeah.
part of your group. Mm-hmm. What are some of the negatives that have come up for you in drinking?
Well, negatives. Well, no one likes a hangover, so that's no fun.
Hangovers. And how often does that happen to you?
I mean, I would say I wake up with a headache on the weekends, one day of the weekend.
And again, just so I'm real clear, how much are you say you drinking most of the week? So when during the week, what would you say you drink, and then on the weekend?
Probably 2 or 3 times
2 or 3
days of the week.
days of the week. And how many during those days would you say?
Maybe 3 or 4
3 or 4.
drinks.
And then during the weekend,
Yeah, sometimes it's
you're
more.
partying with your friends?
Yeah. Maybe 5
5.
in a night.
5 in a night.
Yeah.
How about what other effects have you noticed, or others that are concerning?
Sure. This doesn't happen very often, but definitely I would prefer to never get to this place where I've had a few blackouts, probably.
All right.
Definitely
And,
in college.
In college.
In undergrad, yeah.
What's that?
In undergrad, especially.
In undergrad. And what was concerning about those for you?
Well, not
others?
remembering what exactly happened never feels great. I got into one bad situation in college that my mother was involved in, which was not pleasant.
Really risky to you, to your health, and to your safety, or
Yeah,
bad, like embarrassing? Or?
I would say not usually risky to my health. I feel safe around the people that I drink with for the most part.
Okay.
But there have been a few embarrassing moments,
Embarrassing.
for sure.
Okay.
Some embarrassing photos.
All right. So one thing you said, and I just want to bring that back up, is you talked about wanting to have a family.
Mm-hmm.
And so I'm wondering if, you're pretty aware probably that it's really unhealthy for the fetus to drink
Sure.
during stages of pregnancy. So have you thought about that at all as you've been thinking
Yeah,
about your
absolutely.
drinking?
Yeah, and
Yeah.
my mom stopped smoking and drinking right away when she had my brother. So I definitely plan on doing that. And I think I have more friends from home who are already starting to have kids.
Yeah.
So I think there's some definitely support there.
It seems like you do it socially. It's really helped you feel less inhibited, sounds like. And then you do it frequently on the weekends, really. You let loose that way and have a good time. You have some blackouts that are of concern, right? You haven't seen a lot of effect up till now, although your mom and now your doctor, this time you're concerned, and you said you're also interested in starting a family.
Yeah.
And so that's something that might have you change your mind. I am wondering what would have to happen to you, when you think about it, like what would be an indication for you that this is more like your brother and your dad, that this is something that really is a concern?
I think that I just have been ignoring it, maybe. And that putting all these pros and cons out makes it sort of more an apparent issue. I think the most difficult part is that everyone I'm around is sort of doing the same thing.
Yeah,
So-
and I get that. And that's, by the way,
Yeah.
that's very common for people your age. And I hear you saying that. I guess what I'm wondering is, just personally, would there be something that would tell you, okay, I really do need to cut back? Is there something that would have to happen in your life right now that would say, hey, it's time, and your doctor's concerned, and the tools that we use to examine this say you're at risk, but what has to happen?
I mean, given where I want to be, I think in the future and with having a family, I think I'd like to start cutting back right away.
Right. So I'm wondering, on a scale of 1 to 10, how ready you are right now to take a look at this seriously like you've done today, and then have you bring it down?
1 to 10.
1 being, not at all, 10 being very motivated.
Honestly, like an 8.5, maybe.
Wow, you are very decisive. I can see why. So an 8.5, and what I'm wondering is, I wouldn't have heard it like that. There's so many reasons socially for you to
But it's
continue
really
drinking.
only, I feel like it's really only social. And I feel like if I can't overcome that, that's kind of.
So you feel like those reasons that you're drinking aren't enough to you personally to have you continue at these harmful levels,
Right.
or risky, let's call them.
Yeah,
levels.
I mean, I'm not going to
Okay.
lose friends,
Okay.
I don't think.
Okay. So given that, what do you think you could do in this next week? And I'd like to see you next week,
Okay.
but what can you do in this next week, if that's good with you, to actually change your drinking risk?
Well, I definitely would want to talk to my fiance Ben
Okay.
about it. Not even necessarily get him to cut back, but just tell him where I'm at and what you guys have said. And then with my mom as well, I think my mom would be a great person to hold me accountable, although I would hate to admit that she might be right about my habits. But
All right, those sound like some great steps. Is there anything that I can do to remind you to do those and to follow through on that?
I think seeing you next week will be good motivation for me. And I think if 7 is a weekly limit to work for, then I think probably drinking only on the weekends is something manageable.
So knowing the safe limit and then
Yeah.
limiting it to a set period during the week.
Yeah.
All right, is that something you can try this week?
Yeah.
All right, great. So what I'd like to do is great to talk to you. Do you have any questions for me?
Not right now.
Okay. All right, so I'd like you to go out and make an appointment to see me next week.
Okay.
All right. Nice to meet you.
Nice to meet you too.
Take
Thank
care.
you.
Yep. Bye. So in this first couple of videos, what's the setting? What's the scene that's going to get played out to demonstrate the?
Well, in all of the demonstration videos, our intent here is to try and replicate as much as possible, just like normal people, so that the cases and the case studies that were selected are the kinds of clients or the kinds of patients that you might see in a primary care practice. And we looked through a number of different case profiles and made these selections. And that we tried to really have just the kind of normal SBIRT brief.
Okay, so you're able to kind of see a demonstration with me and Taylor, and then see the brief negotiated interview questions, and then seeing a video of that kind of played out the same, and then them highlighting where those skills are being utilized and the different stages and what's happening. Okay, and the last step is referral to treatment. So this is where the indication of high risk or risky use is evident, and then they're going to need a follow-up with a substance use counselor or a mental health counselor or a psychologist or a psychiatrist. It's some higher level of care to address this specific need that a general practice couldn't, or wherever they're getting this intervention from in the first place. But before I go into that last stage, we're almost out of time, but I just want to make sure everyone has an opportunity to ask any more questions or comments. You can make comments, and I really do appreciate you guys telling what you like or what interested you, because that keeps you engaged and keeps me engaged too, instead of me just talking to my screen. So okay, yeah, I think the video helps to kind of tie it all together. Yeah. That's great. Yeah, Angelica. Okay, so one of the things we want to highlight, especially with clients, is that and folks who don't work in the field yet but are aspiring to, like you, that substance abuse treatment works. When people get into treatment, it has a benefit. It doesn't always have a benefit, but there's some, even if it's a small benefit, and sometimes people go into treatment and they come out and they maybe aren't successful, but there's some measurable change that has taken place. And so sometimes I tell people it's like planting seeds. You just kind of do what you can and are hopeful and have faith in folks. And when they're ready, if they've been given an opportunity, they can make that change. Okay. And then, so what treatment might look like is something you might want to talk about with your clients is counseling, psychosocial rehab service, medications, get involved with self-help or support groups, complementary wellness, better diet, exercise, meditation. When folks start to come out of their addiction and develop a kind of well-rounded life, they realize there's all these other things that life has to offer them that their addiction kept them from enjoying. You know, having trustworthy friends, people who, you know, are motivated and ambitious and have a lot of things going on in their life, supporting their own community, giving back, taking care of their body, taking care of their mind, going to college, learning new things, you know. And you know, any combination of those above. So when your patient's ready, make a plan with the patient. You or your staff should participate in the referral process. You don't want to just give them a number. You should know and interact with the referral agency. We should know it's a good place or not. Some agencies are better than others. Some are poorly staffed, poorly managed. Others are great. So, you know, you definitely want to have some kind of professional relationship with the agencies you're sending folks to. Confirm your follow-up plan with the patient. So let them know how it's going. Ask them to, you know, if you can ask how it's going, or they can come in and talk to you about it. And then decide on ongoing follow-ups and support. A warm handoff is when there's initial direct contact between the patient and the treatment counselor. You might say, hey, let's just give them a call right now, or, you know, the receptionist can help you make the appointment right now. We can call. But you don't want to just leave it up to them completely. You want to, of course, it's their option. You don't want to kind of coerce them into it, but you want to have some support in it, because you just, you know, hand them a business card or a pamphlet that tend to not be as effective. Who do you call? You should have a referral source, people that you know and trust in your community. And then you might have a referral form, so the referral agency can contact them. And then finally here, this is SAMHSA's treatment finder. So they've got a great database on their website, and I'll try to make it as big as I can. Hopefully you can see that. And this is more up to date than anything I have. So you might put in your zip code here. Somebody want to put their zip code in the chat? If I can take a look at it. Okay, 89883. That's West Wendover. Oh, yeah, that's going to be a challenging one. We'll see what's available. So this is a great tool. You can go you know, you've got a bunch of filters here, the kinds of things that are available. It looks like there's nothing in West Wendover. That is just depressing. I'm sorry. But you probably knew that going in there. Let's try somebody else here. 89445. Winnemucca. Not much better. Okay, let's go back out 100 miles. This is the problem. Now, this is the problem, and our program is the solution. Okay, I'm trying to these programs are to provide training and education to create providers in these areas. So this highlights an important problem with mental health in rural communities. We need more of you guys, and hopefully you answer this call to do that, because without somebody taking up the mantle, it's never going to change. Okay. So there looks like there's 3 mental health facilities in this area. You probably know them all. And here, let's see. I know everybody's getting a shout out here. We've got some folks from Hawaii. How cool is that? I really like to see that our program is beyond just the state And we're getting into I saw somebody Hawaii, not 96720. Oh. Okay, this is Hilo. Wow, you've got the thing about this island has a lot more than we do in Northern Nevada. Think about that. What does that mean? So there's a number, they're color coded, substance use, mental health. Looks like that's about it right there. And this could be a great way for you to start to build a referral source, talking to those folks and then knowing where to send folks. And then last, we're going to do Dallas, 219. And boom, this is what a good state tax base. And you know, I'm a very left-leaning Democrat, so don't mean to offend anybody, but I'm born in Nevada. I love Nevada. I'm a Nevada, you know, but when we don't have a strong tax base for the state, we have poor mental health services. Other states like Texas, they have a very strong tax base, maybe too strong because they have really high property taxes, but that's what you get. You get better schools, you get better services in that way. We have to find a way to fund it. I don't know what the right answer is, but I know that's a major issue. Yeah, telehealth isn't the same, I agree, but it's better than nothing. That's another thing. Yeah, there's a lot of addiction issues in the Native communities in Hawaii, and I've been there, and I know that from working with folks that come here because Las Vegas is very popular amongst the Hawaiian islands and folks coming out of there. So Ely does not have a lot but it's growing. And you know, I think whenever you see something that is lacking in the world, then you know, like God, as Gandhi says, be the change that you want to see in the world. And so we have an opportunity to do that. This is why I became a professor. This is why I decided to not just stay in clinical mental health, but go into education, because I thought, okay, I can help X amount of people in my private practice or working in an agency. But if I train generations of mental health providers, then I can make a bigger impact. And my goal, since I came to GBC 7 years ago now, and I was at UNLV before that for 5 years, was to create the best mental health preparation program that I can. And that is in terms of getting you guys ready for licensure in the state of Nevada for substance abuse counseling, and those that want to go on and study in their master's to be very, very well prepared for any master's program or clinical psych program that you might be interested in. So I know, I hear what you guys are saying. There's so much need, but we can't get there by just saying, wow, this is not, you know, this isn't good, or leaving it to somebody else. We have to solve the problem, and we're culpable because we're part of this community and the society, and these problems exist for reasons that are influenced by our own action or inaction as well. So I want to encourage everybody, and I know you guys, I'm speaking to the choir because you guys are here. And I do appreciate that. But it is a calling. I do believe that it takes a big heart and a lot of compassion for humanity to say, you know what, I'm not going to be somebody that just turns a blind eye to this program. I'm going to dedicate my time, my effort, my career, my life to this cause, and you'll find that it's worth it. It's worth it, because even if you make a change in one person's life or help them change, that's enough. That's really enough. So in summary, excuse me, treatment works. Minimal amount of preparation. You can know what's available in your community. Clarify your procedures in your agency to have a good relationship with referral sources. Use warm handoffs and follow up. Yeah, I think that's a good, Kim. I think starting with your children is probably the first order of business. Okay, so we're done. We're just a little bit over time. The password for the event is sunshine, sunshine, sunshine. I know you guys could probably use some of it in Elko. And what you're going to do is you're going to put that password into the assignment, submit it, and then I will give you the grade for attending. Of course, those folks that didn't, if you let them know, they'll be able to watch the video. Don't tell them the password, because then they just put the password and won't come. Thank you guys. I really appreciate the kind words, the interaction, the questions. sharing your life story. I wish I had more time to talk to you guys. Like I said, we're going to have another one soon. It'll probably be around group counseling and the impact that has in treating individuals, especially with substance abuse too, because that's a great medium for providing a lot of services to a large group of people or medium size. Thank you guys. I do really appreciate it. This is a picture I took. I think I was up in Northern Nevada, and I like to use my photos, and so I'm not the only one looking at them. People get to see them. So as always, Dr. Wentz and I are at your service. If you need something, don't feel free to call us, email us. You can text me if you do. Make sure you put your who's texting me, because I don't store students' numbers on my phone. And I just want you guys to know we're here for you. We're here to support you through your academic program, and don't ever feel intimidated or unsure if you can contact us, of course, during business hours, and of course for maintaining a professional student boundary. But we love to hear from our students. I love to see the hard work you guys put in your coursework, and I know you're going to go on to be great clinicians. I know not all of you are my program, but I see you putting the effort. Even those folks coming from radiology, paramedics, nursing that take my ethics class, or the social work folks that take the substance abuse class. It's just awesome to see a wide range of helpers. And I know you're the next generation, and I've been doing this for a long time. And a lot of people have a kind of a negative view of the world, but when you work in mental health and you also I work in education, I see the best of the best coming through people. So I see a real positive outlook because I see people that really care, really want to do something, really want to make a change in the world. And that inspires me to no end. So thank you for that. And thank you for being a part of my day this evening. And everyone have a great night. If you need something else, please let me know. Thank you.